Hi everyone. We're here teaching the Fundamental Club on upper cervical listings, palpation, and instrumentation. My name is Christopher Rowden. I'm a ninth quarter and I'm a Gonstead officer.
And my name is Keisha Valdivieso. I'm a fourth quarter and an officer in training.
What we're first going to start out with is the alignment of the upper cervical. We're first going to talk about atlas and C2, which deals with the dens and also atlas as well. So the first thing I want to talk about is how is the relationship between atlas and C2, structurally in the body. With this demonstration, my arms are going to be the atlas ring, which my hands are going to be the anterior tubercle, chest will be the posterior tubercle, and the elbows will be the transverse processes as well, and our lovely dens will be right here. So what we're going to do first is we're going to just act like our normal atlas is here. So first part of the listing is either AS or AI. Now basically what that meaning is the atlas is tilting either anterior and superior or anterior and inferior, okay? Most of the time it's an anterior superior listing. Now what we're going to talk about is the second part of the listing, which is where is the superior capsule and the swollen capsule. So basically what that looks like is it's the lateral bending on either side. So let's say we'll start off with our first part of our listing, AS. So AS, and then we're going to say R. So the swollen capsule is on that side, and it's when we laterally bend to that side, it's restricted. So let's go back again, AS, L, okay? So the atlas is now going like this, and this is just exaggerated for the learning purposes, but so AS, L, perfect. So now we can go AI, R, awesome. And we're comparing, when we talk about atlas, we're comparing this, the transverse process of the atlas TP, the transverse process of atlas, to the transverse process of C2. So basically there would be two here and we'd be putting our fingers here during the palpation, which you'll see later, and we'll compare to either side. So AS, AI, R, and L. Now that we've talked about that, we're going to talk about the last letter in our listing, which is either a P or an A. So when we're listing these atlas listings, we want to make sure that we're listing on the side of that wedge or that superior capsule, that inflamed capsule that's there between C2 and atlas. So when we're like this, we want to list the right side because that is the superior transverse process. So we have two parts to this listing. It's either anterior or posterior, okay? So let's just do a listing all together. So we'll say AS, R, and then P. So it's rotated posterior. And it's stuck posterior, it won't go P to A basically. So we'll do AS, L, and then A. So it won't go posterior, it's stuck anterior. So one more time, AS, R, and then A. Does that make sense? Okay, so those are the three components of the listing, and just wanted to reiterate this before we do the palpations. Thinking of the listings in all the biomechanics, it's not just AS, R, and then A. It's all moving into a coupled motion. So that will help you out if you think of them all moving together in one motion. It will help you out with the palpation and also the setup, and when you get to that point, the adjustments as well. So now we're going to get into the palpation of the atlas. So first thing I like to do is I like to make sure the patient's in a relaxed position. I know this is a cervical chair, but we had to work with what we work with. I like to have the patient in a relaxed position because the more relaxed the patient is and the more relaxed you are, the more you're going to feel and the more information you're going to get to make a successful specific adjustment. So first thing I like to do is talk about finding atlas. If there's one thing that I want to get you to get out of this basic club is to actually find atlas. So when I find atlas and when I was learning to find atlas, they told me to be super soft. And also you want to be super soft so you don't get anybody sick by poking on their atlas or anything. That's a very sensitive area of the body. So what we're going to do is you're going to pull the hair back just a little bit. And what I like to do is I like to take my two fingers. What I do is I put the middle finger on the mastoid, the inferior part of the mastoid, and I like to put the pointer finger a little bit above. So what I'm gonna do is I'm gonna slide a little bit anterior and inferiorly until I feel kind of like a little pebble, okay? You're not gonna feel like a C2 spinous, like it's not gonna stick out at you. You might have to imagine it first. So once I find that atlas, what I like to do is roll my other finger in to confirm it, okay? And I'll show you guys something at the end that will help you with your setups too. So what we do is we come down, roll, I touched it with my middle finger, roll the second one to confirm, and then you can move back and forth. We can rotate just to feel that under our finger, okay? And then we wanna find this on both sides. You can also take the head and actually have them relax against you a little bit, and you can actually find the atlas this way as well with a middle finger or ring finger contact. And just same thing, sliding down, finding it, reinforce, there we go. So now we're on it and we're actually feeling that atlas in our hands. So that's the most important part. If you don't find atlas right and you're not on the right bone, you're not gonna be able to palpate it right. So I would recommend if you have someone who's an upper quarter or anything like that, make sure you're checking your atlases. If you're in the right place or you're on the right spot. So first what we're gonna start off is we're gonna talk about the AS and AI. So for an AS and AI, you have to get those off of x-ray. There's some docs that say that you can palpate them and all this stuff. I'm not at that level yet. I have to look at an x-ray to find if it's an AS or AI. So that will not be part of our palpation portion because we will find that off of x-ray when we take our full spine images. So now that we have this, we're gonna do the same thing as before. And I do the same thing every time I find atlas. Even now, come off the mastoid, roll down, touched it with my middle finger, gonna confirm it with my second finger. Okay, so now this finger is now on the atlas TP right here, okay? What I'm gonna do with this other middle finger is I'm gonna put my finger right next to it and I'm almost gonna feel for the C2 TP. So we're gonna compare the atlas TP to C2's TP as well. So we're gonna roll down. Okay, I found atlas and I wanna find the C2. And you can do it all in a couple of motions just to roll down C2, atlas. And you see how close my fingers are together? They're not like this, they're not like this, they're almost touching because that's how big the transverse process is. I mean, that's how close they are to each other. So the first thing we're gonna talk about is we talked about our AS and AI on x-ray. We're gonna figure out which that wedging is. Remember, we're gonna find out where that swollen capsule is, where the atlas and the C2 meet. So how we're gonna do that, we're gonna roll down it like we did, find atlas TP, roll down to C2, put my finger on atlas. Atlas is here, C2 is right here, and these are the transverse processes. Then we're going to slightly laterally bend into this side. So I'm not bringing the whole head over like this. You can actually probably see her SEM just fired up. It's almost, I'm feeding it with my hands and I'm just segmentally palpating those two transverse processes. And I want to feel them come together like this. They should almost come together. And if they don't, that could be the swollen capsule on that side and that would be the side that we list. And then we would do that bilaterally to make sure that they are both the same, or if they're different, we're gonna palpate more. So we've now rolled down and we've found the atlas TP, C2 as well. So we laterally bend. Let's just say the right side is a little fixated. So our right side is fixated. It won't laterally bend in that side. So we have, let's just say she had an AS. So we have an ASR at this point. So we're going to stick here and we're gonna laterally bend into it to feel that restriction. So now what we're gonna do is we're gonna keep our fingers, remember, do the exact same thing. I promise you, you keep doing this, you're gonna find atlas. Go down, check with it with the middle finger, roll down, check with the pointer finger, and then my fingers on C2 transverse process. So now what we're gonna do is we're gonna talk about the rotation. So what we're gonna do is we're gonna put our two fingers here, and also another thing is, when you're palpating, make sure you're not pokey and proddy. You want an open hand. Like, since I've been going through quarters and adjusting a lot more people, I like to put like a firm, relaxed hand on people, like especially if I'm palpating in this region. So she knows I have her. You know, I'm not constricting or anything, but I'm also not like this either. I like to just, you know, a firm grasp or like hug with your hand in a sense. So we're gonna come down. So for the rotation, we're going to rotate away and we're gonna go rotate towards. Now I want you to pay very specific spotlight on my finger because I'm gonna over exaggerate it here just for the demonstration. It's not usually like this. So let's say the atlas transverse process will rotate back. Now watch my finger. It should rotate back comparing to C2, okay? Let's say it doesn't rotate this way. See, it's stuck. It's not going like this. My finger should go forward. So that's when we're going to get the rotation. We're comparing the C2 transverse process still to atlas transverse process. So if we rotate this way and this finger doesn't go forward and we don't feel the atlas go away, that's stuck P, okay? If we keep the finger here and the finger doesn't come back and we rotate this way, like I just explained, that's an A. So when you talk about the P's and A's, it's where it's stuck and won't go. So if an atlas, so we'll just talk about the atlas, AS, R, and then P, it's stuck this way. It won't go this way. So when we adjust it, it's gonna go from A to P and then down. I mean from P to A and then down, okay? So if it's an AS, RA, it's stuck anteriorly, so we wanna bring it this way, okay? And when we palpate that, we're gonna say, okay, so finger should move like this when we rotate this way. That top finger should move. And we come back this way, should move that way. If it doesn't, it's either stuck either in A or P. Last thing that I wanna, and this is a lot for the basic club, and it's so much better in person, and putting your hands on people and having an upper quarter or somebody who knows what they're doing, putting your hands in the right place and confirming what you're actually doing and actually feeling is such a benefit. Another tidbit that I like to do as well is what I do is, remember that whole slide down feel, kind of looks cool too. When I go to the setup, what I do is I have my stabilization hand already in contact, I slide down, crossed it with my middle finger, crossed it with my pointer finger, replace this finger, S to I tissue pull, boom. Now I'm taking her into the atlas setup, okay? So that just makes it so much, so you know exactly where you're on. You know, when we take tissue pulls in knee to chest or on the pelvic bench or anywhere, you know, it doesn't change for cervical chair and atlas. So we tissue pull S to I, pass it with the middle, pass it with the pinky, the pointer finger. This, I still have that S to I tissue pull. This thumb's gonna slide in, still S to I. That AS, so we're torquing down for the AS, because remember AS is like this, so we gotta torque down to get that atlas to go down.
So now we will talk about scoping. We normally use a delta T or a nervous scope to kind of help us with the findings. We want to start with the probes as far as we can. We do not want to put them in a narrow position and just basically going over the spinous. No, we just want them to be as wide as possible because the nerves goes out laterally, not medial. And then we will start by doing the lower cervicals first, and then keeping that light, not a slight, but a light pressure, but at the same time a sustained pressure on both sides. If I'm just scoping like this and then there's an air gap, this is gonna be a wrong reading. At the same time, if I'm doing this and I air gapping the other way, it's gonna be a wrong reading. We want to be with both of them with equal pressure, but not poking the patient's neck or making them uncomfortable. It's most like a sustained pressure for you, so you can just know that you're actually going over every segment and every vertebrae, but not as much pressure to put the patient into an uncomfortable position. Also, when you're scoping, you want to slow it down when you're hitting up, because the hair is making, it can make some interference with the equipment. So we just want to, as we gliding over, we just slow it down and then read it and slow it down and do it as many times as we can, so we can be sure that we're actually having a reading on top and not something that is misleading by the patient's hair. Also, we want to start in a lower segment, and then we spend 3 seconds per each segment until we hit the top part. And if you can see, I'm tilting the instrument as I'm going up the neck. I'm not doing this. I'm not, if this is curved, which you can see that it's curved, I'm not like curved all the way up. No, I'm just here following the next curve. So he's a little bit tilted here. I'm following that, and as long as I'm going up, I'm moving the scope with the patient's neck. Also, when we scope, we want to put the scope in a low setting, so we do not have any interference from the hair or any other misleading things. And what we're looking for is a fast break or a fast needle movement. And if the needle is like slowly moving side to side, that would mean a heat break. But if the needle is like slowly moving back and forth, that would mean a break. And we do this as many times as we can. Then we slow it down in the upper, going back again, slowing down in the uppers. And if you think that you find a break, then you just mark the area. Let's just say that I had a break on this side. You mark the area and then just come to the patient. And then again, you find the atlas and you find the C2, and then you start laterally bending, rotating away. If the atlas and C2, they seem fine, you come here to the lowest part of the occiput, the mastoid and the atlas, and then you come here, start palpating, start rotating, and at the same time, you start challenging the occiput.
Okay guys, we just want to say a couple last remarks based on like what's helped us out through school and what's helped us up with palpating, adjusting, doing anything with this upper cervical area, because it is a very difficult area, but also a very, very important area for a lot of our future patients. One of the things that I would like to say is, especially when you're in younger quarter and you're palpating and you're trying to find out all this stuff, when you scope, I basically always check the upper cervicals when I'm scoping the cervical spine, and the reason is because the hair gets in the way and it just gives you a lot of misreadings. So I love to I always, when I scope the cervical spine, okay, no breaks, I come over and I do all my quick palpations, everything's moving okay, talk about symptoms, look at the x-ray, all that stuff, perfect. But I always, and it's a really good thing to just, when you're first practicing, palpate the upper cervicals. It's just another time where you can palpate something to make yourself more familiar with it. And also, lastly, I'd like to say that she did a great job explaining, the scope and explaining what we do with the scope. One of the things that I want to repeat is when we have that slow deflection back and forth, that's a heat swing. And then a break is going to be like this. It's going to be that small deflection. It's going to be, I even still have trouble finding it and all this stuff, but we just want to, when you're using your scopes or you're using your instruments, just make sure that you're looking for that small deflection. Thank you guys all for coming today. We really appreciate it, and we can't wait to see you back in person. We hope you have a great day, and thanks again.
See ya.